I'm Dr. Vigneswaran. I'm one of the esophageal surgeons at University of Chicago, and it's really a pleasure to be here. I love talking about everything esophagus, especially to patients. So this is a real pleasure to be here to talk to all of you. Some of this you may already know, so it's very high level in terms of just giving you some information so that hopefully you can take it however you want and talk to your doctor more about it. And so if you ever have any questions, please feel free to ask at the end of the talk. Well, I'll try to leave some time to do a quick Q&A, but you can also reach out and I'll make sure you have my contact information. So today I'm going to start by just briefly going over what your esophagus should normally do, the normal anatomy and how it should work, how scleroderma specifically can affect your esophagus, review various treatment plans and treatment options, as well as complications that esophageal disease can lead to. And then I'll briefly talk about some new studies we're doing at University of Chicago that you may be a candidate for. So the esophagus is a structure that connects your throat to your stomach. It's a very smart, actually, tubular muscle. It's about 8.5 inches long, and as you can imagine, it starts up in the back of your neck, and it goes all the way down to connect your stomach and your abdomen. The way it works is, and we'll see if this video works, it basically, in a very coordinated fashion, should push the food down through your esophagus through muscle contractions. Again, the esophagus is a muscle, and it squeezes in a coordinated fashion to push the food down into your stomach. It goes through what we call the lower esophageal sphincter at the bottom of the esophagus, which should act like a one-way valve. So it should allow the food to go down into your stomach, but it should prevent anything from your stomach coming back up into your esophagus once you're done swallowing. Should, yes. And so what can happen with scleroderma? There can be damage to this muscle, just like others. The esophageal muscle can be scarred, weakened, and this can affect coordinated contractions or coordinated swallows when you're using your esophagus. Also, it can weaken that valve at the bottom of your esophagus, and so it can make the valve weak or completely dysfunctional, and that allows stomach acid, but not only stomach acid, anything in your stomach from coming back up into your esophagus and causing what we call gastroesophageal reflux disease. And over time, this can progress, and the esophagus can become weaker, and it can become less effective over time. In fact, there's been some studies that have shown that up to 90% of patients with scleroderma actually have some kind of esophageal symptoms and some impact over their lifetime on their esophagus. So like we were talking about, this can lead to acid reflux. That can lead to inflammation of the esophagus and damage to the esophagus. One thing is that we also talk about, not enough probably, but reflux can also impact your lungs, because whatever's coming back up into your esophagus can also go down into your lungs, and we call that aspiration. Especially when small amounts continue to go down into your lungs, it can cause slow damage to your lungs as well. Symptoms that you might notice if you're having esophageal problems: heartburn is the typical one. So feeling that burning sensation in your chest or up in your throat. That can be worse after meals. Sometimes it can just be worse after certain activities or exercise, or after laying down. As we talked about, since this can affect how your esophagus squeezes, you can notice some trouble with swallowing. It can be as little as occasionally feeling things get stuck. Oftentimes that patients who have trouble with their esophageal muscle will find more trouble with things like breads or meats or steak that are a little bit more difficult to go down. You might need to take some extra water or some liquids to get things to pass, or it just might take longer to go down. As I was alluding to with aspiration, sometimes people can have respiratory issues that are from the reflux itself, chronic cough, hoarseness, or asthma-like symptoms, but obviously that can be due to a lot of different things. And then nighttime, a lot of my patients who suffer from reflux or trouble with swallowing, actually it impacts their sleep a lot. And that's because when you're lying flat or lying down, things tend to, you don't have gravity to help you to keep everything down in your stomach. And then lastly, can affect your vocal cords. Because if, all of that is coming up into your esophagus and back of your throat, over time it can cause a lot of irritation to your vocal cords as well. And so sometimes people have constant throat clearing or coughing, which, post the COVID pandemic has been something that's socially impacted a lot of my patients because having a chronic cough, people, don't want to get close to you or things like that. But that it's not due to any kind of viral illness, that it's related to the reflux actually. And then some patients will experience changes to their voice over time, becomes more raspy. I've had singers that I've operated on for reflux because it's affected their vocal cords to the point that it affects their singing. So if you have these symptoms, there's a array of different tests we can do to see how your esophagus is functioning. These are the 4 major tests that we do when we're trying to determine how your esophagus is functioning or dysfunctioning. So a barium swallow, or we call an esophagram, this is a special type of x-ray test. Essentially what you'll do is you'll drink a liquid that can be seen on x-ray, and then the radiologist will take a video x-ray basically of how you're swallowing. They'll put you in different positions. This gives us a lot of information about the anatomy of how your esophagus is functioning. It'll also give us some ideas if you have something called a hiatal hernia and how things are passing into your stomach. Another test that we frequently do, especially for patients with scleroderma, is something called manometry. This is a special test that will actually measure how strong your esophagus is squeezing and whether it's squeezing in a coordinated fashion. It's not a very pleasant test, so we try not to do it. I don't know if anyone's had that test, but it is a test when you're awake and you have a probe put down your nose into your esophagus, and then that catheter will actually measure the pressure as you're doing some swallows. But it does give us quite a bit of information about how strong your muscle is squeezing. And then the most typical test, which I'm sure several of you have had in this room, is an endoscopy. This is basically a camera exam of the inside of your esophagus. I think this is important. I don't know that there's any official recommendations for patients with scleroderma, but if you're getting a screening colonoscopy, probably should tell your doctor to check your esophagus too while you're asleep, because the esophagus is affected in so many patients. It doesn't hurt to have someone just check to make sure you're not having silent reflux and having any damage to your esophagus that we need to monitor more closely. And then pH testing sometimes can be done with manometry. There's a couple different ways to do this, but essentially what we're doing is measuring how much acid is coming up into your esophagus. It can be done over a period of 24 to actually up to 96 hours. You go home with a device. There's different devices that are used, and it will measure how much acid is in your in your esophagus, so that we can determine whether it's an abnormal amount of acid coming up. Again, so what can be seen on these tests? So the manometry, like I said, it can show if you're having contractions, if there's weak contractions, or if there's impaired muscle function. The barium swallow can show us if the contrast, so that's the x-ray video, if things are going down normally, if there's some narrowing anywhere, or if your esophagus has started to enlarge because of some changes that are happening. And then again, the endoscopy will check the health of the lining of your esophagus. We worry about things like strictures or Barrett's esophagus, and I'll talk a little bit about that more, but essentially those are sequelae of long-term inflammation of your esophagus and things that we want to keep an eye on if you have that. So medical options, if the muscle is affected, can be difficult to treat these symptoms, and a lot of times what we're trying to do is palliate your symptoms. The most important thing is making sure that your scleroderma treatment is optimized, because obviously if the underlying disease is treated, that will help with the esophageal muscle as well. But in order to help treat some of your esophageal symptoms specifically, a lot of times we try acid suppression medications. So proton pump inhibitors and H2 blockers, those are the common two drug classes, which I'm sure many of you have had to take at some point. We all have. Acid suppression is one of the most prescribed medications in the country, so don't feel too special if you're on them. And there's over-the-counter acid suppression medications, but essentially these medications work by reducing the amount of acid your stomach is making. The one thing I try to tell patients and make it clear, your stomach is not making an abnormal amount of acid. That's not why you're having reflux symptoms. You're having reflux symptoms because the valve in your esophagus is not functioning well. So it's more of a mechanical problem. So the acid suppression medications can help temper the symptoms, but it's not necessarily fixing the underlying problem. And so there can be side effects with long-term acid suppression use, but sometimes it's the only way to get effective relief if you're having bad reflux. There's also some other medications we call prokinetics that can help with esophageal motility or stomach motility, if that's also part of the problem. And then there's a lot of other lifestyle modifications, as we call them, diet changes, so smaller, more frequent meals that allows your esophagus more time to swallow and allows your stomach to pass food without it getting too full and refluxing back up. Sometimes I'll tell patients keep a food diary. You can try to identify what foods trigger your symptoms and then try to avoid those foods. Sometimes it can be a lot of foods, so it's not always a pleasant exercise. And then limit eating late at night. And so it takes at least 2 hours for everything to empty from your stomach. So we say to try to avoid eating anything to at least 2 hours, 2 to 3 hours before you go to sleep, because again, once you're laying flat, you don't have gravity to help you anymore. And so if your valve is open and your stomach's still full, things will come back up into your esophagus. And then at night, positioning of the bed. So sometimes some of my patients, especially patients that, not just scleroderma patients, but other patients that suffer from esophageal motility problems. And so when I say esophageal motility, when there's problems with the esophagus squeezing, they do sleep with their head elevated. Some people have beds that do that. Otherwise, the most common thing is getting a wedge pillow or sleeping with multiple pillows under your head so you're propped up just a little bit. Usually we say 30 degrees is a good amount so that it gives you a little bit of gravity to work with when you're sleeping. Staying upright after meals, sometimes sleeping on the left side can also help. So complications, we talked a little bit about this. So aspiration, again, because the reflux can come up into the back of your throat, it can also go down into your lungs. And even if it's small amounts, it could put you at increased risk for inflammation. Sometimes patients have recurrent pneumonias due to their reflux disease. Barrett's esophagus. So your esophagus, will try to protect itself from seeing all the caustic material in your stomach. Your stomach makes acid. There's also bile in your stomach and enzymes that digest your food. Your esophagus really shouldn't normally see large amounts of any of those things. So it can be corrosive to your esophagus. That's why you have those symptoms. But what your esophagus will do in response to that is over time it will try to change the lining of the esophagus, the cells in the lining of the esophagus. It'll start to change to look more like intestinal or stomach cells in order to protect itself from those materials. And so we call that Barrett's esophagus. The reason that's relevant is when the cells start to change to another cell type, it puts you at slightly increased risk of those cells changing to a cancer cell. So it's still an extremely low risk, but it is higher than the average population. And so that's why I say if you're ever just getting a screening colonoscopy, it never hurts to ask them to take a look at your esophagus, because sometimes people won't feel the symptoms, but they'll have silent reflux. And so at least we can, stay ahead of it and try to get rid of those cells if they're there. And then esophagitis, which is a fancy word for saying inflammation in the esophagus, that can lead to not only the symptoms and the pain that you feel with reflux, but it can cause ulcers because, again, it's like a corrosive material coming up into your esophagus. It can cause bleeding in severe cases, so sometimes patients become anemic because of these ulcers. And then it can cause strictures. So because it's causing inflammation, it can cause scar tissue in the esophagus. And that hard scar can narrow your esophagus, and that can add to the problems you may already have with swallowing. Those types of problems can be treated. So strictures or scar tissue can be broken up if it's developed, obviously trying to manage the reflux better so that that scar tissue doesn't continue to develop. And then quality of life. This is something that's kind of dear to my heart because I feel like esophageal problems really affect your everyday living, and sometimes you've got a long list of other medical things that you need taken care of, and reflux and your esophageal symptoms sometimes fall to the end of that list and may not always get addressed, but they do affect your everyday life. And so I think, I have a lot of patients that, it affects them being able to be social, being able to go out, being able to eat and sit with their friends and eat dinner without feeling anxious that something's going to come back up, or certain foods that they can't eat. It affects your sleep. Everyone needs their sleep. I know I'm not very happy if I don't get my sleep. And so it affects your, the whole day if your nighttime routine is disrupted. And then the thing we worry about the most, which is in more extreme cases, but obviously nutrition, want to make sure that you're able to get in good food and avoid any kind of nutritional deficiencies or weight loss. So why early diagnosis matters for some of these symptoms. It can prevent long-term complications. If we know there's something going on, we can start intervening sooner. We can try to be more aggressive with medical treatments, and so that we can avoid long-term damage. Obviously, every patient is different, and especially with scleroderma, and I'll talk a little bit more about this. Your esophageal disease is very special, and so your treatment needs to be tailored accordingly. And then, like I said, regular follow-up, whether that's with an endoscopy or just, talking to your gastroenterologist about what you're feeling. And then hopefully it can help you just live a better life if we can get control of your symptoms earlier. Medications, so sometimes medications aren't enough. So there's not a lot of studies about scleroderma and esophageal disease, unfortunately, but some of the studies that we do have show that up to 53% of patients will still have symptoms despite being on maximum medication therapy. And that your risk of having lung complications from uncontrolled reflux is 2 to 3 times the average person that doesn't have these reflux symptoms. And so what do we do when the medications aren't enough and lifestyle changes aren't enough? So I'm a surgeon. I'm not here to talk you into any kind of surgery, but I do a lot of esophageal surgery, and so sometimes we talk about esophageal surgery for reflux disease. Sorry, the slide should say, why do symptoms continue on maximum medical therapy? And so just to go back and review why the reflux happens. So it's a mechanical failure of the esophagus. And so like I was saying before, a lot of the medications don't actually help with the mechanical failure. They're essentially just trying to help treat your symptoms, but don't address the underlying issue. And so in scleroderma, it's a little bit more complicated than this, but the lower esophageal sphincter, or that one-way valve at the bottom of your esophagus, when it's not working, it'll allow things to come back up into your esophagus. So the problem is a dysfunctional valve. But in scleroderma, it's a little bit more complicated than that, because it's not only that the valve is not working, but the muscle might not be squeezing hard enough either. And so we call that poor clearance. So 1, the valve is not working, so things are coming up, but 2, the muscle's not able to squeeze things down well either, and so that allows things to stay in the esophagus. And so traditionally, when we talk about anti-reflux surgery, what we do is we address the underlying cause, which in most patients is the valve is not working. And so the type of surgery we do for that is something called a fundoplication surgery. It's a fancy word to basically say that we're going to wrap part of the stomach around the bottom of your esophagus to tighten up that area and tighten up that valve. It's done through small cuts. And basically what it'll do is recreate that anti-reflux barrier so things can no longer come back up into your esophagus. So here on the right, there's a picture that shows this is your esophagus. I don't know if you can see my pointer there. So there's the esophagus there, and this is the stomach. And essentially what we do is just take that very top part of the stomach. It's like less than 10%, it's even smaller amount than what this picture depicts, and just wrap that around the bottom of your esophagus to tighten up that area. The goals here is that it's a one-time solution to fix that underlying mechanical problem and get you off your medications and also get better control of your symptoms. You know, when we do these surgeries, we obviously do a comprehensive assessment. We often get a lot of those tests that I talked about earlier because, again, we want to make sure we know exactly what is failing because if we do a surgery, we want to make sure it makes things better and not worse. And then, again, the benefits are to get you off the medications, get your symptoms better controlled, and prevent further esophageal damage, as well as improve your quality of life. So when you're talking about surgery in scleroderma, you have to be very careful because, again, your esophagus is not like the typical person. And so the typical anti-reflux surgery, we do something called a Nissen fundoplication, which is a specific type of stomach wrap. And what it does is it involves wrapping the stomach 360 degrees around your esophagus. It's the tightest type of stomach wrap we can do. For scleroderma, sorry, my animations are off here. For scleroderma, this type of surgery can actually worsen your swallowing problems because that 360-degree wrap can be so tight that now the muscle that's already weak to push things through is going to struggle even more. And so if you are a candidate for anti-reflux surgery, it's really important that your surgeon or provider understands this and customizes the surgery to your esophagus. Because we don't want you to have worse problems after surgery if you have the wrong type of operation. And so if you seek care about anti-reflux surgery, I really encourage you to ask your surgeon if they've operated on patients with scleroderma before and what their opinion is about your esophagus in the setting of scleroderma, because it is a little bit different. And so it's not that you can't have anti-reflux surgery, it has to be thoughtful. And so, like I said, it's not a lot of literature on esophageal disease and scleroderma, but there's even less on surgery in scleroderma. But what we do see, and this is what I've seen in my practice, is that scleroderma patients still do well if we do a partial wrap. So not a full 360-degree wrap, but something closer to 90 to 270-degree wrap, where you're getting a little bit of extra valve function without making it too tight so your esophagus can still push through normally. And it seems to improve patients' quality of life. They do better. We do see that in our practice, and we see that in the literature from other groups as well, that long-term quality of life is improved with this type of operation. At University of Chicago, we're doing a new type of surgical approach to anti-reflux surgery, and I actually believe that scleroderma patients could actually be the most to benefit from this type of approach. And essentially what we are testing is that, do you even need any kind of stomach wrap? If we can just restore your anatomy back to normal and close that diaphragm nice and snug around your esophagus, can we avoid the side effects of trouble swallowing, but still get control of your reflux. This is a little bit more involved for me to explain how this works, but essentially the brief kind of few-minute spiel is that the valve is actually not a physical valve. So a lot of the pictures you see online where it shows the lower esophageal sphincter as a a flap there and that there's a valve. There actually is no valve there. If I cut open your esophagus, there's not actually a spot where I can say this is the valve. There is a lot of muscle and fibers in that area, but a lot of why the valve works the way it is because of your anatomical position of the esophagus. And so, like I said at the beginning, the esophagus is a long circular tube that connects your throat to your stomach. So most of your esophagus lives in the chest, but a small portion of your esophagus lives below your diaphragm muscle in your abdomen. And so the diaphragm separates your chest from your abdomen, and it's that bottom part of the esophagus in the abdomen that is very important. That anatomy is important because your abdomen is a pressurized compartment compared to your chest, where you take nice big deep breaths in. It's almost like a vacuum. So in that pressurized compartment, the bottom part of your esophagus actually stays collapsed because of the external pressure from that compartment. And so it keeps it collapsed so things can't come back up. But usually you can squeeze with enough force so that it can push through that collapsed esophagus to let food back into the stomach when you're swallowing, and then it collapses back again once you stop swallowing. So our whole theory is a lot of patients who have valve failure, it's because that bottom part of the esophagus has actually moved and it's migrated into the chest. And it's what we call a hiatal hernia has occurred. And so essentially now that esophagus is in your chest and it just stays wide open because it's not in a pressurized compartment to keep the bottom of your esophagus closed. And so what we found in our early results is that by just restoring your normal anatomy, you can get improvement of your reflux, and especially in patients with underlying problems with esophagus squeezing already, we're not augmenting it more or making it tighter, preventing your esophagus from squeezing. And so, sorry, it's very, very involved, so if there's questions, please ask later. But so this is a trial that we have patients that are undergoing right now. Many of the patients who have had this type of procedure have showed reflux control without the side effects of trouble swallowing, gas, bloat, increased flatulence that we see with traditional anti-reflux surgery. We have lots of patients that are very happy. We're continuing to collect long-term data because we still don't know. I've only been doing this for about 3 to 4 years, this study, so I don't know how long these effects last. But the goal is to eliminate the reflux symptoms without impacting swallowing. And so this is one of my patients. She did a patient story for us, Laura, who was suffering from reflux, and she was really happy that she did the surgery. She said she wished she had done it sooner, and the most important thing is her husband said, you are a completely new person, because I think sometimes our partners and our family are the ones that hear all the complaining the most, and they really understand what's happening more sometimes than we do. And so this type of surgery, or even a traditional anti-reflux surgery, usually it's pretty quick recovery. I say it's a safe and pretty similar to having your gallbladder removed if you know anyone who's had their gallbladder removed. You're on your feet right away, but gradually return to activity even in the first week. The restrictions after surgery are usually diet related because there is some swelling from this type of surgery around your esophagus. So while that's going down, we do have you on a special diet. And usually most patients have a full recovery by 4 weeks. So I'm going to slow down here so that there's time for questions if there's any. But the take-home message is reflux is common. It's common in patients that don't have scleroderma. It's one of the most common GI disorders, and so it shouldn't surprise us that reflux is also common in patients that suffer with scleroderma, and that you just need to be aware that your esophagus is different, and so the pathology of your reflux may be different as well. Obviously, medications and lifestyle changes are the first step in addressing your symptoms, but I think I would also add making sure you're getting the right tests and surveillance as well. And then if surgery is considered, it must be tailored. And obviously, we have some options for you that might be different than what you have heard of already.